Now, may I request our third speaker, Dr. Dorcas Gandhi, to give her insights on the topic, evidence and future scope of mirror neurons. Dr. Dorcas, over to you.
Thank you, Dr. Lakshmi Prabha. Thank you, Scientifica committee, for this opportunity, first of all. And I would like to second what ma'am mentioned just now about Dr. Vijay Kumar's talk. The last slide, in fact, said it all. The vision of a cat seeing the reflection of itself as a lion says it all about the mirror neuron therapy. So I will focus on the evidence and what is in store in future with respect to mirror neurons and therapy based on mirror neurons.
Excuse me, ma'am. Ma'am, there's just one thing. Could you please use it on the full screen? Like share the screen.
Oh, yes. Thank you so much. All right. Is that okay?
Yes, ma'am. Perfect.
Great. So these are my disclosures. I just want to remind the audience, which these points have already been spoken about by the previous two panelists, just to remind that this mirror therapy is a form of enriched environment. So there is a multiple numbers of inputs going into this brain when we are using mirror neurons. This induces, very interestingly, true recovery when compared to compensation or spontaneous recovery. And this has been identified not just by the paper mentioned here by Arya KN, but many other analyses as well. And as mentioned by Dr. Utra, we know that it has been used and useful in motor impairments and sensory motor impairments, visual spatial neglects, even in orthopedic conditions, CRPS, etc., in probably different stages as well. And it exploits the brain's preference to use visual feedback over somatosensory inputs. However, we do know that even the somatosensory inputs are a crucial role, play a crucial role while using mirror therapy. So I will skip these slides because they have been very wonderfully covered by our previous panelists. Coming to the evidence and hitting on the bullseye, right from 1995, Ramachandran et al. Spoke of its role in phantom limb sensation. Moving on to numerous studies right from 1999 till 2022, which talk about its role in stroke, upper limb as well as lower limb, in visuospatial neglect and hemi-neglect, etc. We also have huge evidence right from 2003 on various stages of CRPS. However, stage 1 of CRPS is where we see most positive effect of mirror neuron therapy. And lastly, we also there are a few cases which also show improvement in peripheral nerve injuries, but the sample size and the quality of the studies, methodological qualities, are very poor to show effect of mirror neurons. And probably we'll discuss this in the future if time permits, of why mirror therapy may not be as useful in lower motor neuron lesions when compared to UMN conditions. Now, this was a meta-analysis done by our group in 2021. If you see here, in the acute phase, when we talk about brainstorm recovery stages, and we have compared the mirror neuron therapy versus conventional therapy, which included various types of motor and sensory motor training. We included in the acute phase, we found that we had only 4 studies. So the results, clinical implications can be questionable. However, the heterogeneity is quite less, 0.34, which means that it is still not bad evidence. And using these calculations in the meta-analysis, we found that it was significantly improved in the acute phase. This is the brainstorm recovery stages that we are talking about. Again, in the hand brainstorm recovery stages versus conventional therapy, when we assessed, again in the acute phase, we see even hand shows significant improvement. Warning to see that there were only 3 studies. Heterogeneity was a little higher, 1.05. So clinical implications, we need to be careful. Now, both these, through both these analyses, we can say that there is level B evidence for arm and for hand brainstorm recovery with mirror neuron in the acute phase. Coming to chronic phase, unfortunately, we did not find many studies in the subacute phase. So in the chronic phase, when we talk of FMA scores, this is with respect to stroke exclusively. When we compared mirror neurons and conventional therapy, we got a good number of studies, 6 of them. Heterogeneity was quite high, 8.64. And with the high amount of heterogeneity, we did find a significant improvement with mirror neurons. Again, clinical implications, we need to be careful because of the high amount of heterogeneity. Coming to functional independence measure, we consider only the self-care subsection because most of the studies used only this subsection. When mirror neuron treatment was compared with conventional therapy in the acute phase, with very low heterogeneity, 0.29, but only with 3 studies, it still did show a good improvement with mirror neuron therapy. Now, this is an interesting find. A film showing improvement in the self-care subsection right in the acute phase. But then again, like I said, number of studies is quite low. We have spoken about the modes. I will not go into the details. Dr. Vijay has clearly covered it. If we have to talk about the dosage of mirror neuron therapy, for stroke, the evidence says that a duration of 20 to 90 minutes per session, that was the range that the studies covered, a frequency of 3 to 5 sessions per week, and at least 4 weeks on an average needs to be given in a patient with stroke. Now, this considered subacute as well as chronic strokes. For the upper limb, there was an average of 20 to 60 minutes per day over 5 days a week. And for lower limb, at least 15 minutes, least to maximum of an hour per day for 5 to 6 days a week. Now, this can vary in with other factors like patient's cognitive factors, patient's premorbid status, patient's ability to understand the therapy and things like that. So those factors need to be dealt in with when you are customizing the therapy for the patients. As of now, this dosage that I mentioned in the previous slide that we have published in 2020 is not given as a protocol because it needs to be standardized across various races, across various sample types. However, there is just one protocol that has been published and does not have great evidence, which is St. Gallen's protocol. Now, this is the link. Please feel free to go ahead and look at the details. There are a few prerequisites which have already been discussed by the previous panelists. Explaining to the patient is one of them, of why we are doing it. I mean, why is the unaffected limb being worked in such a therapy needs to be clearly explained to the patient. The patient should be able and willing. You always use a quiet environment. Customize, individualize these programs for the patient, especially when you are thinking of a home program with mirror therapy. Use of mirror therapy diaries where they're noting down what they're doing, how many times they're doing, the duration, and any other observations is very, very essential. Now, this gives them kind of a feedback that most people are use as indicators to improve their progress, their protocols. Now, assessment on a timely basis to understand what adaptations they require, what changes in intensity they require is also a prerequisite. And lastly, pre-decide what outcome you need to have in the patient along with the patient, and of course, document the progress. So these were the prerequisites according to St. Gallen's protocol. In the process, I have just highlighted the main points here without going into too many details because other panelists have covered it. There may be paresthesia-like sensations, even in patients who have CNS lesions, not just phantom limb cases, but even with central nervous system lesions, with mirror therapy, patients may show paresthesia-like sensations that they may define as unusual or pricking and tingling kinds. This may last for a few weeks or days or weeks, but that is normal unless it gets painful. In my little experience with mirror therapy with patients of central nervous system lesions, these paresthesia-like sensations were reported in around 10 to 20% of the cases, but none of them turned out to be painful or uncomfortable, so the therapy could continue over a long period of time. Performing bilateral movements is another added component that St. Gallen's protocol talks about, and we also use in our clinical practice. Using therapeutic aids, like Dr. Vijay Kumar already mentioned, the transitive approach, actually performing those movements also is included in the St. Gallen's protocol. These are the few other protocols which talks about mirror therapy in phantom limb sensations, in stroke, where they talk about the dosage of at least twice daily exercises for 15 minutes. But please note, this is quite an old evidence. The newer dosage was previously discussed about. And like I mentioned before, CRPS stage 1 has good evidence. Level B, I can say a maximum of 10 minutes, and as long as the patient can manage to do mirror therapy. Now, this particular paper in 2004 by Mosley et al., again for CRPS stage 1, even CRPS due to stroke, we have used it in our patients in our institution, where there are 3 stages: recognition and the hand laterality, where a computer program is used to show the images, and then imagine the hand movements. I hope you are, comparing this to the previous talk by Dr. Vijay and how these stages go. So all those 3 types and in 3 different stages are being applied in this CRPS stage 1 patients. And lastly, mirroring of the movements. Now here, when we say mirroring, some of the patients, it was not just having a mirror in the sagittal plane, but the patients were repeating, mirroring the images that were moving on the screen. There are a few examples of how we can progress it. Again, in the St. Gallen's protocol and a few other stroke-based trials, these activities were used. First of all, consider increasing the load. Then you can consider.
Sorry to interrupt you. We need
Yes,
to abide by the time.
Yes, I'll be done at some time. Thank you, ma'am. Then moving on to increasing task complexity, and lastly, increasing the speed. And these are the various examples. There are a few interesting things about mirror neuron system that I'd like to add on. There is evidence that MNS and language, there is a connection. So listening to and viewing speech enhances the motor evoked potentials, the amplitude for the orbicularis oris muscles, and this also has been used in speech language training. Lastly, MNS and emotions. The human mirror neuron system is also concerned with social cognition, so understanding the intentions of other people in collaboration with the limbic system. So use of fMRI data for social mirroring, use of them in autistic cases, etc., is also being studied, which is very open for research and is a current contemporary topic. So I hope this gives you a little idea about where we stand with evidence, and thank you once again for the opportunity.
Thank you so much, Dr. Dorcas, for letting us know what is the most recent advance in mirror therapy and what is its future scope also, and for giving us a comprehensive dosage for treatment with motor neuron therapy. It was very informative. Thank you very much, Dr. Dorcas. We would like to move on to our next part of this panel discussion. Since we have understood the basis, we have understood the techniques in mirror therapy, and we have understood what is the latest evidence, we would like to enhance the learning here by posing a case-based discussion so that our panelists can give us recommendations about the same, so that, and even there is some conceptual understanding in people who are listening to this. So we go ahead with the next part, that is the case-based discussion. We would like to invite each panelist to give their ideas about the cases that we will discuss here. So the first case is of a 49 years old lady who had right MCA infarct 7 days back, following which she had hemiplegia and unilateral neglect of the left side. She has generalized flaccidity on the affected side and is cognitively sound. The question posed is, what type of mirror neuron-based rehabilitation would you suggest for this patient for both upper and lower extremity? And to answer this case-based problem, may I invite Dr. Vijay Kumar? Can you please help us in understanding this question and let us know what is your opinion on it, the view on it?
Thank you, ma'am. It was interesting. Was about right MCA stroke, and basically it's post-stroke 7 days, so acute stroke, and she is presenting with flaccid presentation and also some neglect issues. So what type of mirror neuron-based rehabilitation would you suggest for this patient? So basically this client looks like cognitively sound, and maybe other parameters like the trunk control or the visual system, that guides us what basically we are looking into that. We can start with mirror therapy or action observation. Like we can start with some kind of videos which is showing some activity of upper extremity functions, or even we can use with mirror therapy, just to tilt the patient of some degrees from the bed, and we can work on with the patient to improve their function. But for graded imagery or motor imagery, I think the patient need to be have little more imagery abilities to screen that. Basically, that can guide you to go for motor imagery. So my opinion for this case, I start with mirror therapy initially because flaccid state. So as I said earlier, if you're not moving that particular hand or your brain, the somatosensory map is going to get changed, or it's going to get reduced as the condition progress. So we need to at least create some illusion to the brain that that affected part is still working, so that we can activate that somatosensory part of the brain. So I recommend, or I may go for initial stages with mirror therapy. Just start with some simple movements of the unaffected or the sound arm or the sound hand. Then I can also work on with the patient little more. She can able to tolerate the session. As even the madam said about the dosage, minimum 20 minutes is recommended to have some effect or changes in the recovery. So if she can able to tolerate the session, then I can go for one more combination of action observation therapy, just seeing the videos of the healthy individual, how she performs with the upper extremity task. So that's my opinion. Other panelists can have their opinion with regard to this case. It's always welcome.
Yeah, thank you, sir. May I ask the other panelists if they are interested in sharing their views on this case? Please go ahead.
I was just wondering if even the mental imagery aspect, like Dr. Vijay was mentioning, could have some added advantage. And from personal experience, the staged approach of first few minutes of mental imagery, then moving on to mirror therapy would really be beneficial for the acute case. Thank you.
Uttara ma'am, would you like to add something to it?
I would also like to add that in mental imagery, every patient may not have adequate ability in imagery. So we can first assess the ability, like by using vividness of visual imagery questionnaire, to see if they have the ability to imagine the movements. If not, like Dr. Vijay mentioned, we can go for action observations or mirror therapy. Also, maybe in the later stage, we can also work on the unilateral neglect also. So that would require mainly interventions in sitting position. So after a couple of sessions, once the patient is able to sit, we can address that as well by using a mirror therapy approach.
Thank you so much, panelists. Now we move on to the next case, which is about a 50 years old male who was diagnosed with left CVA 5 months back and now has voluntary control grade 3 in the right upper limb. The patient has severe pain in right wrist and is a diagnosed case of complex regional pain syndrome in stage 2. How can mirror neuron based rehabilitation be useful for this patient? I would request Uttara ma'am to please start giving her views on this case. Thank you.
For a complex regional pain syndrome, there are various mirror neuron-based interventions that are used. There is evidence for use of motor imagery, for mirror therapy, and also in a graded motor imagery. To decide which intervention I would go for in the initial stage, it will depend on the patient's clinical presentation. So I would look at the severity of pain, also the patient's ability for a motor imagery, if they have a good ability or not. So in case the pain is there during movements, like which is commonly the case in complex regional pain syndrome, so maybe we could start with a couple of sessions of motor imagery, wherein we visualize the different movements or task which requires the affected movements. So the motor imagery can be performed as about 30-minute sessions. which could be 4 or 5 days a week. Initially, we can try for 3 or 4 weeks of intervention, followed by reassessing with outcome measures. So VAS is commonly used, visual analog scale, and we can see if the pain symptoms are reducing, if the patient is able to do movements and go ahead with further rehab. If not, we can increase the intervention for some more weeks. Okay. And in using the motor imagery, I would suggest that we can start with a third person kind of motor imagery, then go for first person, because in CRPS quite often the pain is very severe in movements. So sometimes even imagining movements can induce memories of pain during those movements. So progressing step by step will help. Also, the intervention could include initial few sessions of less painful movements that's been performed in imagery, later progress to a more painful movements in a graded fashion. Also, mirror therapy can also be used, wherein the mirror is placed in the sagittal section. So in case the patient's motor imagery abilities are limited, you can instead prefer a mirror therapy. So again, in this 30 or 40 minutes of interventions in every session for at least 4 or 5 days a week, and we can see the progress. Once the pain intensity reduces, then we can go further on to facilitating the movements on the affected side for the upper limb function to improve the motor function once the pain is more tolerable. In certain cases, there is also difficulty in right and left discrimination. Because of this pain causing central sensitization, cortical changes, some patients might have difficulty in discriminating, or the pain might be too severe to even manage with the motor imagery or a mirror therapy. In that case, we can proceed in terms of a graded motor imagery, where we first start with training left-right discrimination. So we can use different posture cards to see if the patient is able to differentiate which is the left body part, which is the right body part. And in this, we have to see the accuracy of identification and the response time. So for an upper limb, the response time expected is 2 plus or minus 0.5 seconds. So if the patient is able to identify accurately, we can do this for a week or longer, depending on how the patient recovers. Once the discrimination is improved, then we can go for a mental imagery. So at least the graded motor imagery should progress weekly. If required, a particular level of intervention can continue for a further week if the patient's recovery is not very significant. And then after motor imagery, we introduce mirror therapy for the same movements where the intact limb performs a movement. And then we can progress to training the affected paretic upper limb in performing those tasks where we want to improve the voluntary control or functional skills of the patient. Thank you.
That was very elaborate method of giving us the idea about the technique of graded motor imagery for CRPS. Thank you very much, Uttara ma'am. May I request the other panelists, if they have some views to share regarding the same case, please go ahead.
Yes, as Uttara madam suggested, it was very challenging. Even we had some clinical cases post-stroke with CRPS. It's very challenging for us to initiate a movement or to guide the conventional therapy sessions. So as madam suggested, we also tried with some mirror therapy sessions, but it was quite interesting that we got some responses from that. And as clearly madam said, basically the motor imagery, we need to have some kind of imagery ability, and the challenging is more challenging for the patients because their education level, their other parameters which can influence that training program. But with respect to mirror therapy, as madam said, it was quite improvement in the lines. And basically the upper extremity function with CRPS is very challenging, and even as madam suggested, yes, it is working in that condition. That's my opinion.
Thank you, sir. Dorcas ma'am, do you want to give any feedback?
I have nothing to add, ma'am. Thank you. They have wonderfully covered all aspects.
Yeah, thank you so much. So we just quickly go to the third case. That's a 23-year-old male was diagnosed with foot drop 2 months back, and now has grade 1 strength in right ankle dorsiflexus. How can mirror therapy benefit this patient? May I request Dorcas Gandhi ma'am to address this issue?
Thank you for the question. And considering the cause to be a lower motor neuron cause for foot drop, and I strongly feel that mirror neuron would not have much of a role in this case, because we have seen that for any case, it's the cause that we target. And for such a case where the central nervous system is intact and usage of the superior temporal gyrus or the areas where mirror neural system, neurons are activated will not directly influence the lower motor neuron case. Having said that, like I showed in my talk, for brachial plexus injury, there is very poor evidence. With a small sample size, studies were done, but the evidence is quite poor. Also, there is a consensus-based recommendation for brachial plexus injury, which talks about mirror neuron. Clinically, however, we do not see any changes in patients, in my experience. So mirror therapy in this case is a no-no from my side. Open to other panelists.
Madam Dr. Gandhi, do you have any studies related with this area like element lesions from your literature search?
No, sadly, in our literature, we only considered central nervous system lesions. But then 2004, the Mosley study, along with CRPS, they did talk about brachial plexus injury. So there they showed poor evidence, sir. So I'm not very sure how applicable it is, though. Clinically speaking, it does not show, and even neurophysiology of mirror therapy does not support, its use in LMN lesions.
Okay. Thank you.
Thank you, panelists. I think these three cases and the discussions and the talks that you'll have given has provided us with a good amount of knowledge about the use and application of mirror therapy, in which conditions it is used widely and where it is not recommended. I think it was a very wonderful discussion. I'm very happy to be a part of this panel discussion. Now, since we are done with the case presentations, we come to the question answer section. May I request Dr. Franny to please carry on with the question answers from the audience?
Yes, ma'am. Thank you, ma'am. That was indeed a wonderful presentation by each and every panelist. But since we are running short of time, so maybe if we could take just one question that is already been asked in the chat box. Can mirror neurons help in treating the learning disabilities and children having behavioral issues? If there's some evidence that talks about the role of mirror neurons in children with learning disability or some other behavioral issues.
Can I take that question if that's okay?
Please, ma'am.
So like in my talk, I mentioned MNS and the language system, MNS and emotions have shown some connection, and there is minimal evidence for it, but more research needs to be done in this field. In autism spectrum disorders, this has been used successfully for training. So I think extended application into learning disabilities is also possible. However, there is no strong evidence as of now.
Thank you very much, ma'am.